Chris Kruger, Senior Manager for Content with the Davis Phinney Foundation, and I'm here today with Dr. Kara Beasley to talk about deep brain stimulation for Parkinson's. And specifically, we're going to talk about the timing of when someone with Parkinson's might think about and actually have DBS surgery. So before we get started, Dr. Beasley, thanks for joining me and taking some time out of your day. I wonder if you can start off by sharing your experience in Parkinson's and how you got started with your expertise in DBS.
Yeah, so I am a fellowship trained neurosurgeon in stereotactic and functional neurosurgery, which is the branch of neurosurgery where we perform deep brain stimulation for Parkinson's. And so I got affiliated. I became affiliated. I should use the right word. I became affiliated with the Davis Phinney Foundation when I started my practice approximately 14 years ago in Boulder as a DBS and functional neurosurgeon. And I became interested in deep brain stimulation when I was a resident. I also have a master's in bioethics, and it seemed like that was a very nice marriage of bioethics and neurosurgical interventions. I also was just completely blown away when I saw my first DBS and to watch the results both intraoperative and postoperatively. And so I said, this is it for me.
Yeah, it sounds like a really great sort of combination of your interests, right? You have an opportunity to view and experience a surgical procedure that makes a major difference in somebody's life, and then you also get to marry it to your other interest in the ethical components of providing care and living with a chronic condition. So, yeah, it sounds like a nice fit.
Yeah, DBS is a more complex decision than perhaps you do some spine surgery or what have you. And so there are ethical implications to that. And it's a nice way to sort of look at the entire experience holistically.
Yeah. Well, great. Thanks for that quick overview of your background. So maybe we can jump in to talk about some timing concerns that might relate to DBS. But before we get there, let's talk a little bit about a quick overview, if we can. Can you just give a quick overview of what DBS is and how it works as a treatment for Parkinson's?
Sure. DBS stands for deep brain stimulation. It's where we place a wire into one or two deep structures in the brain that are electrical signals. If you think of the brain as one big electrical system, what we do is we modulate specific electrical systems to override the tremor, stiffness, or rigidity, slowness, also known as bradykinesia, of Parkinson's disease. That wire is then connected underneath the skin to a battery or a generator in the chest wall, somewhat similar to what your friends may have with a pacemaker or what have you. And then we can deliver electricity continuously. The other thing that we can do with deep brain stimulation is we can adjust it over time.
Okay, so maybe that points to my next question, I think, and maybe I'm wrong, but I think you can run with this question either way. So you mentioned electrical signals and symptom control, but how does DBS actually accomplish that? And if medications are sort of not doing a good job, how does DBS maybe help do that a little better or differently for people?
So medications have to do things like cross the blood-brain barrier and have certain effects. And over time, medication wears off, becomes less effective. So people will notice that they require an ever-increasing dose of medication. They will find that the medication has these wavering on-off experiences where one time it will work for 4 hours, another time it will work for 2 hours. Sometimes it takes an hour to kick in, sometimes it kicks in sort of right away. And then there are some side effects that some of the medications cause that are uncomfortable or intolerable. Deep brain stimulation is across the blood-brain barrier, as it were, in as much as we're providing direct electrical stimulation to the area. And because it's adjustable, we have the ability to turn it up, turn it down, make some non-invasive modulations to the stimulation to really provide personalized treatment for those symptoms, whereas medication is really, here's your dose. You can take more, you can take less, you can take it sooner, you can take it later, and we can adjust those. But to be very clear, DBS is very good for tremor, stiffness, and slowness, but it does not treat the other non-motor symptoms of Parkinson's, such as constipation, cognitive issues, it does not treat drooling. It does not treat some of the non-motor symptoms of Parkinson's. And so medications are usually used in conjunction with deep brain stimulation.
Let's transition into talking about the timing of DBS surgery. I think I hear people with Parkinson's often say, sort of existing on a spectrum here, where some people say, I want to take as few medications as possible, as quickly as possible. And they hear about DBS and they get very excited. They want to have DBS surgery as soon as possible. I also hear people say things like, I can't imagine having brain surgery. This is why I think the timing consideration comes up, because people do sort of exist on this spectrum and they have to make a decision. When do I want to start pursuing and beginning the process of determining if I'm a candidate for DBS? And so I thought we might talk about how do we get to that point? When is it important to get to that point as a person living with Parkinson's? When should you start thinking about DBS? And I guess my first question is there a too soon for DBS surgery?
There is a too soon now, at least for data. And so I think thank you for asking the question, because I think that outside of who is the right candidate, this is the most important question when it comes to deep brain stimulation. And there's a very specific reason for that. There is this window in which deep brain stimulation is available and effective, but falling outside of that window on the far end, you may not be a candidate. If you wait too long, you may not be a candidate for deep brain stimulation. And we know that deep brain stimulation is effective lifelong. So if you wait to the very end, and I can talk about what that window is, you wait till the very end and you're not a candidate, you've fallen outside that window, then it is a treatment option that you may then want that's not available to you. And if you had deep brain stimulation, you would still be getting the effects from. And so that window is the following. It is when medications are effective outside of tremor. There's something called tremor predominant Parkinson's or tremor refractory Parkinson's, where the tremor doesn't respond to medication. We don't really care if tremor responds to medication. We know tremor will improve in the brain, but specifically rigidity and bradykinesia, because those are the three major things that deep brain stimulation treats. Medication needs to be effective. So if you get to a point where your medication is no longer working, you're like, okay, now's the time for my DBS. That's too late. And then when medication starts requiring higher and higher doses, or when it becomes less predictable, or you develop abnormal side effects or uncomfortable side effects, such as specifically dyskinesias, that's when one might begin to look at deep brain stimulation. Immediately after diagnosis is, in my opinion, not the right time to look. There are things that look like Parkinson's disease, idiopathic Parkinson's disease, called Parkinsonisms, that aren't Parkinson's disease. And so some of those do not respond well to deep brain stimulation and can respond poorly. So we want a time period. And so we used to say, back in the day, you had to have symptoms at least, or a diagnosis for at least 5 years, and you had to have those medications. Now we have very good data that shows that it is safer earlier in the disease process when those medications just start requiring increasing doses and have those fluctuating on-off symptoms. So that would be the beginning of the window. And then the end of the window is when medications are no longer effective or when you develop a moderate to severe dementia. And not everybody with Parkinson's develops dementia, right? However, it can be a component of Parkinson's. And if one develops a moderate to severe dementia, then it is an absolute contraindication. Sometimes people will think about other modalities surgical options that don't seem as invasive as brain surgery, because that sounds like a very scary thing, like a pump or what have you. The problem with those is that then people want deep brain stimulation when the pump isn't as effective or the dyskinesias become severe, and they may then again fall outside that window that we've discussed. And so sooner rather than later, but there certainly is this window. And the most heartbreaking thing that happens for me is somebody has waited till the very end. Either family was like, this is your last resort, or you must wait till the very end. And they come to me, and for either on-off testing purposes or cognitive purposes, they're no longer a candidate, and it's not something that I can offer. And they're pretty devastated about it because they were using that as sort of their last resort. And it really isn't a last resort.
Yeah, so I think you said a couple things there that point to the answer to my next question. So let me see if I can ask the next question, see if there's something else that you want to add to it. So I wanted to ask you what the advantages are to considering DBS earlier in the course of one's time with Parkinson's. And I think the main thing I heard you say was, first of all, that quality of life improvements from DBS can be and often are significant. So that's one reason that jumps out to me. That's a great advantage to doing it early. If you want to improve your quality of life, why would you want to do that later rather than sooner? So, but what else falls into that category of reasons and advantages to considering DBS earlier? Can you just summarize those again for me?
Yeah, so quality of life for longer, because the data is overwhelming that it improves all areas of quality of life: bodily discomfort, medication burden, social interaction, social isolation, every area or quality of life that we test in medicine, there's an improvement in quality of life. So that's it, for me, a no-brainer. I did in fact intend that pun, by the way. Um, so the other one is medication burden. There are two targets in the brain, GPI and STN. The STN target would allow somebody to decrease their medication burden by about, on average, 50%. Earlier on, I have many patients that have come off of medications for a period of time, and as their Parkinson's progresses, they can add back in. That is super important, particularly if folks have dyskinesia, because dyskinesia is directly related to medication dose. And so if you can cut your medication dose back by on average 50%, or perhaps even more, then you have a lot of room as Parkinson's progresses to add that medication back in without the side effects that can be burdensome. And then the last big one that I think of is that with DBS, the older you get, and we do DBS now well into people's 80s, et cetera, you may develop a health problem that is not related to Parkinson's that would keep you from having surgery. You might develop a cardiac problem with that would then make it unsafe to have surgery or what have you. And so having surgery when you're younger and healthier across the board, it doesn't have to just be deep brain stimulation. It could be your knee or your hip or whatever it might be, is always better from an anesthesia standpoint. The generator is always put in under general anesthesia. And so if you, for some reason, can't have general anesthesia from a medical perspective, or you have a cardiac problem or such, you may then also not be a candidate for DBS, even though it has nothing to do with your Parkinson's.
Yes, that's interesting because, I'll speak to my own experience as someone who lives with Parkinson's. I sometimes think, well, if there's an infusion system for me now, maybe that sounds less invasive, so maybe I'll do that first. But then what you're just saying now makes me think, well, yeah, that makes sense on one level, but on the other hand, if I do that for long enough and then I'm not eligible for DBS down the line, I only have one option. Whereas if I did DBS first, I would theoretically have two or more in terms of being able to have the DBS surgery when I'm younger, healthier, more suitable candidate. And then later, if I need to add the continuous infusion pump, I could do that. But that doesn't necessarily work the other way around, depending on circumstances. Is that fair to say?
Correct. And the infusion system has a couple of downsides that folks don't think about. So once deep brain stimulation is implanted, it is entirely buried under the skin. There's nothing outside of the body. There's nothing the only thing that you have to mess around with, as it were, is you have a controller that you can turn it on or off. You can change programming and control, but that's just a device you carry with you that you hold over your generator, or near your generator. And it's not anything that you have to continuously add. It's not anything that's sticking or hanging out of your body that might then prevent you from doing things. The other thing is, if you look at the complication rates for the infusion system versus deep brain stimulation, the infusion system has an incredibly large number of complication rates. Most of them are infection site around the pump and those types of things, but it's still complications that are not present with DBS and are at a lower rate than deep brain stimulation. So even though it feels like it's less invasive, it's actually got a lower complication rate. My final concern with infusion systems are folks have that thought. They're like, I'm going to use the infusion system and I'm going to wait till that stops working. Well, that might also push them because it's dopamine, right? That might also push them outside of the window of having deep brain stimulation. My thought process would be quite the opposite. It would be do deep brain stimulation as your first surgical option. And then deep brain stimulation doesn't cure Parkinson's. You still have to take medications. And over time, as Parkinson's progresses, you'll have to add medications back in. That might be a better time to add in an infusion system. Or if somebody's not a deep brain stimulation candidate, that might be a time to look at the infusion system.
Yeah, thanks for filling that story that I sketched in the beginning, filling that out, because I think it's a very important conversation to have for people with Parkinson's. And I think that the net effect here for me is that if you're living with Parkinson's and you think you might be at the point where you need to change something significant about your treatment plan, you really should talk to your physician as soon as you can, because there's some timelines here that you need to keep in mind. That's why we're having this conversation. So, thanks for getting to that point for us. Can I ask you a couple questions to sort of ask you to clear up some things I hear in my position at
Sure.
the Davis Phinney Foundation from people with Parkinson's, some questions, thoughts, concerns I hear. So here's the first one. DBS is only for people with severe symptoms, and I don't have severe symptoms. My symptoms aren't that advanced, so it's not for me. What do you think about that?
I disagree. And the reason I disagree is because if you have symptoms that are treated by deep brain stimulation, then deep brain stimulation can be for you. The more severe the symptoms, as we said, the less effective DBS is. And let me say this. So, for instance, if you have DBS when you are earlier on in the disease, then many times people say, I feel relatively similar to the way I did prior to Parkinson's. Not all the time, but they will say that. Whereas if I implant somebody with more severe symptoms, one, it's probably less effective medication. So there's that window piece again. But also it's only going to be so effective on those symptoms. And so they'll still feel their Parkinson's more than somebody who perhaps was earlier on in their disease state when they underwent DBS. And then as Parkinson's progresses, then you have more and more room for both medication, but for symptoms to progress to a way that becomes more difficult to deal with over time. But DBS hands down would be the better approach for that. So I think it's, again, not the best approach. I don't want to say wrong because there's nothing wrong. It's your journey, but it's not the best approach if you talk about like overall quality of life. And overall, like really experiencing deep effect from DBS for longer.
Yeah, okay. Thanks for that that context. I do want to sort of reiterate what you just said, which is just the point that, we're talking about this as if it's in general terms, and everybody has their own experience of what's tolerable for them, what their risk profile is, what they think about the type of surgery that DBS is. So, by all means, people need to consider this from their own personal life and their own perspectives. But, thanks for the perspective that you just shared. So another one that I think you've already talked about this. Another question we hear a lot is, or comment we hear is, well, any surgery is risky, and brain surgery is even more risky than most. I think you've already talked about that generally, but I'm wondering if you can talk about the reversibility in particular, and how that maybe is a factor into the thought process that people might not consider.
Reversibility is very important. And I hear it most, and maybe you don't, but I hear it most like, what happens if something else comes along? What happens if there's a cure? What happens if there's, genetic stem cell work, whatever that might be? The beauty of deep brain stimulation is it is removable. It does require surgery to remove, but it is reversible in that way. And so if the cure for Parkinson's comes along, and my fingers crossed that someday in my lifetime and yours, we will have that, then certainly you can have a small surgery to remove it. Or if you didn't even want to remove it, you could just turn it off, right? You could leave it there and turn it off, but it is reversible in a way that some of the other treatments for deep brain stimulation from a neurosurgical perspective are not.
Great, thanks. So one of the other questions I hear a lot relates to speech and cognition and the way DBS can impact those experiences. And people are concerned about that. So can you offer a little bit of your experience? What is this? What's the story here with speech and cognitive issues with DBS?
So I'll deal with cognition first. And so from a cognition perspective, that is why we are so so strict about that neuropsych evaluation. What we know is that people who have moderate to severe dementia, when they present for evaluation, those folks are not candidates because deep brain stimulation could indeed worsen cognition. And for folks who have a mild dementia, that's when one would want to stage the procedure. And what I mean by that, you may still be a candidate if there's a mild cognitive concern, but you would do one brain lead, and then you would wait a month or so, and then you would do the other brain lead. Conversely, you would probably choose the GPI target, which is a little gentler on cognition if somebody has a mild dementia. And so cognitively, that's where things come in. If somebody gets implanted without neuropsych, and they have a cognitive problem, that can worsen. And if they do have a small or mild dementia, then we need to be very thoughtful about staging the leads a month apart or so, and then choosing the GPI target in those folks. If we talk about the other pieces of DBS that people get concerned about, specifically speech. Deep brain stimulation can help with speech, meaning it can help sort of as you slow your speech down and your voice is less rigid, it can clear it up. But as Parkinson's progresses, there can be this slurring of speech. What most people hear about when deep brain stimulation is talked about and speech, it's that it can in and of itself cause a slurred speech. That is typically something that can be worked around with programming. So it's because the electricity is stimulating a specific part of the brain that's then causing slurred speech. So if deep brain stimulation is done awake, you can actually test for slurred speech in surgery, so that if you are a little too close, and by a little too close, I mean like a millimeter too close to the area that is controlling speech and people's speech slur, you can actually make a move away from that. We also have directional leads, meaning that we have leads where we can send electricity in certain directions. And so if people develop program-related or DBS-related speech slurring, we can then often turn off or turn on certain areas of the stimulation and try to drive electricity away from that and improve speech. So the reason I do deep brain stimulation awake, your brain has no pain sensors, is specifically so I can test for those areas in your brain versus, the guy next to you or the lady next to you with Parkinson's, which they should be very close, but they may be a millimeter, 2 millimeter difference.
So it sounds like there's two things here. Tell me if I'm getting this right. On the one hand, Parkinson's can, as it progresses and as you live with Parkinson's longer, you may develop speech issues regardless of DBS. So the picking out whether DBS is a factor here or whether it's just the progression of Parkinson's may be a little bit blurry. Although you also said that the second piece of what you said was that the programming issue, you can sort of work around a lot of the things that are triggered by a speech issue that is triggered by DBS. Can usually or often there are ways to work around it by changing the directionality of the leads and also potentially moving them if the directionality didn't solve the problem.
Correct. And the speech issues one gets with Parkinson's that just occurs, a softening of the voice, a slight a rapid speech and a softening of the voice that can make sometimes things difficult to understand as someone progresses. The speech issue that is DBS related would be a slurring of the speech. And it's because it controls or can lock down some of those motor pieces, and the tongue and the mouth don't work as well. The beauty of it is you turn DBS off and it goes away, and you turn it on and it comes back. Then that that's a deep brain stimulation related speech area. And typically, because we have such advanced programming and we have directional leads, we can help correct for that. And in surgery, if it occurs, I want to be away from that. I want to move away from that if I can.
Great. So are there any other common sort of, I don't want to call them myths, but common concerns you hear from people that you'd like to add to this part of the conversation?
Oftentimes what people say with wearing off of DBS or becoming less effective is actually Parkinson's progressing. DBS is not a cure for Parkinson's. We do not have a cure for Parkinson's. And so as Parkinson's progresses, even though you're delivering electrical stimulation, people will note some symptoms coming back in. The first thing that we do there is we reprogram. can we control this with programming? Can we deliver a little more electricity? Can we deliver it in a way that helps with those symptoms? However, and oftentimes when people say, well, it's not working anymore, and then unfortunately somebody has an infection, as it were, and they lose their DBS, and they really see that actually, and they become very rigid and become very slow, and their tremor comes back. They see, well, gosh, yeah, I had some rigidity, I had some tremor, I had some slowness that was coming back in. But man, that thing, it is really, really, really helping me in a way I didn't realize. Now, we never want somebody to lose their stimulation, but what we can see is that even though Parkinson's progresses and it seems like DBS is becoming less effective, it's really still working. It's just the progression of Parkinson's.
Okay, great. Yeah, thanks for those additional points. I actually talked to somebody yesterday who was saying that exercise doesn't seem to help him with his symptoms. And then he said, well, it doesn't make my tremor go away, but I didn't exercise yesterday. Now I'm really rigid today. And I said, well, wait a minute, you might be missing the forest for the trees a little bit, because on the
Right.
one hand, yeah, your symptoms, you might not have everything get totally, resolved in terms, you might still have a tremor, but if you're not, extremely rigid, that sounds like a win to me. And if you can say that really, anyway, you see where I'm going.
Oh, yeah. And I'm so glad you bring up exercise because, as we know, exercise has overwhelming and compelling data for Parkinson's. One of the deals that I make with my Parkinson's folks is it's hard for you to move. That's what DBS helps you with. It helps you move better, less rigid, helps you move faster, helps you without your tremor. So my deal is that you then have to go out and exercise, right? Because now we've helped you move better, but the exercise is that added piece. And so if you put in DBS and you don't exercise, you'll get a result. But if you put in DBS and then you go exercise, man, that's the I don't want to say magic bullet. It doesn't take away everything, but that is the special sauce, right? So it's always my deal with my folks with Parkinson's that, I'm going to help you with the DBS moving better, but then you got to go move. You got to go enjoy what it is that we've accomplished here with our work.
So that's another thought about timing, right? Because if as you normal processes of aging also have an impact on mobility and exercise capacity and those sorts of things. And not to say you can't exercise and you can't move well when you're an older individual, but you can build up more strength, and the earlier you start doing that, I think the better is at least as far as I know.
Yeah, if you maintain muscle mass, if you maintain that a little more flexibility. But even folks who are pretty rigid and pretty stiff or less mobile, because like I said, we do DBS into folks' 80s, you can do dance for PD sitting in a chair, right?
Or pedaling for Parkinson.
Or pedal for Parkinson's, where you're sitting and you're pretty stable on that exercise bike. So there are ways for everyone to exercise, no matter who they are. And I say this not even to my Parkinson's folks. I'm like, yeah, you're 90, but you can sit in a chair and move around or do chair yoga or what have you, but you have to keep moving. And the earlier you are able to do that regularly, if you say, well, Parkinson's has kept me from doing these things, and you can move better, the more muscle mass you will maintain, the more flexibility you will maintain, and the better off you will be long term.
So another reason to think about this maybe a little earlier than you might have thought as a person living with Parkinson's, it's not a last resort in that capacity, at least. So we talked about infusion systems and the way they might intersect with DBS and the deliberation about DBS. But I wonder if we can also talk for a couple of moments about focused ultrasound, because I think that's another thing that people sometimes think about now, especially now that it was recently approved for bilateral application in Parkinson's. So can you just tell us what is focused ultrasound, and maybe just how does this relate to the thought process surrounding DBS and well, I guess let's just start there. What is focused ultrasound, and how does it work for people with Parkinson's?
Yeah, so focused ultrasound is a way to create a lesion or burn a small hole in the brain in those circuits. It disrupts the circuits in a different way. Instead of adding electricity, it disrupts the circuit by sort of breaking a part of the circuit. And we have done that traditionally for years, decades with radiation. The advantage to focus ultrasound is that we burn this small hole in the brain, but we can real-time test that we are in the exact right spot because it's done awake in an MRI scanner. So we can test and watch symptoms get better before we actually burn the hole. And I do both. I do focus ultrasound and deep brain stimulation and so some people would come to me and say, well, hey, I want focus ultrasound because it does not require an incision. It does not require an implant. And so that's better for me. And there are some disadvantages and advantages of focus ultrasound. One is there's no implant. So for instance, if you have an infected knee, you have an infection that you're on lifelong antibiotics for, and we probably don't want to put a wire in your brain that could then get infected and cause an issue. And so folks who are not candidates for an implant for a reason like that, folks who are not a candidate from a surgical perspective. You can't undergo anesthesia. You can't really tolerate a general surgery. Focus ultrasound is performed real time in an MRI and is performed without any sedation. And so that might be a reason to consider focus ultrasound. There are a couple of disadvantages to focus ultrasound in as much as right now it is staged, meaning you can only have one side done. And then you have to wait, I think it's 9 months is what the data shows before you could have the other side treated. And so it's not, while DBS requires an implant and a generator, you actually get a result faster with programming and with DBS if you're considering bilateral focus ultrasound, because you'll have to wait many months to get the other side done. There are side effect profiles. So you're burning a hole, right? You can't take that hole away once you burnt it, and you can't make it smaller. You could make it bigger, but you can't make it smaller. And so from that perspective, it's not a reversible treatment, whereas deep brain stimulation is a reversible treatment. It's also something you cannot use. Let's say you have one DBS on one side, you were tremor predominant, you only got your DBS put in for one side, and then you develop symptoms on the other side. You do not have an option for focus ultrasound because of the DBS wires. You do have an option if you did focus ultrasound to then go back and do DBS at a later time. But again, we get into that window for deep brain stimulation. And then the side effect profile can be permanent. Whereas for DBS, you turn it off or you move it or you change the programming. The final disadvantage to focused ultrasound in my mind is that it's not as robust long-term. So we know that deep brain stimulation will be effective lifelong. While Parkinson's progresses, it will be effective lifelong. Whereas for focused ultrasound, it becomes less and less effective over time. And at least in essential tremor, that's where it was first approved, we can sometimes do a retreatment. It may or may not be that we can retreat in Parkinson's down the line. But again, if you're going to undergo something, then something that's going to be long-term effective, adjustable over time, we can program, we can make it harder. That has advantages in Parkinson's. DBS does over focused ultrasound in my mind. What is focused ultrasound? Since I did all of that, focused ultrasound is where we're burning a hole, right? We shave the head. You have to shave the entire head because hair can deflect ultrasound. We screw a frame to the skull and then bathe the head in cold water so that we can then use anywhere from 700 to 1,100 different sources of ultrasound all around the head. As they pass through the tissue on their own, they don't damage, just like doing an ultrasound of a baby or what have you doesn't damage tissue. But however, if they all focus, hence the term focus on one tiny little spot in the brain, then they can heat that tissue until they burn a hole or kill off those cells. You would do it real time in the MRI. So you have to be able to tolerate an MRI. You have to be able to spend quite some time in an MRI, but you do it real time and you're able to test, and then you deliver, and typically results are relatively immediate, meaning you get up off the table and if your tremor was like this, now it's like this, and so you get that instantaneous, but then you have to wait for the other side. I think it's a little better in tremor predominant Parkinson's than it is for other features of Parkinson's. There are some new and interesting targets that are experimental for focused ultrasound in Parkinson's that may have better results, but as it stands now, with approval. In my opinion, for Parkinson's, deep brain stimulation is far better than focused ultrasound unless there's some reason somebody cannot undergo
So
DBS.
can I ask you a follow-up just to make sure I understand
Yeah.
the reason that
Mhm.
why something you said is true? So you mentioned that DBS it can be a lifelong treatment.
Mhm.
Two things about that. First, the efficacy or the degree to which you receive benefit may change over time, but it will help
Yes.
over time. So I just want to make sure that that I understood that right.
Yeah, so to give you an example, the oldest person I've ever replaced a generator in was 101, and she was very debilitated in a nursing home. But when her generator died, she became completely non-functional. And so a 15-minute surgery under local anesthesia to replace her generator recovered enough that she could feed herself again and she could move. And she obviously did not have her DBS placed when she was 101. She had it placed, much earlier than that. And so I can tell you outright that we know that there's effect uh, for decades and decades, whereas we don't have that data for focused ultrasound, and we have some data in the essential tremor field that it may not be as effective for as long.
If somebody is considering both of these treatments, how would you recommend they go about? What things should they think about if they're thinking, well, focus ultrasound versus DBS? Why would somebody go either way?
Again, it's very much personal choice, but and so you need to have a conversation with your neurologist, your movement disorder neurologist, with your um, care partners, and with your neurosurgeon. And I really think that if you are considering both options, that you talk to a neurosurgeon who does both. And not every neurosurgeon does both. Focus ultrasound just received very recently its Parkinson's approval and has not been available in the United States for brain. It's been available for other things, but for brain indications, as long as deep brain stimulation, and it's a very expensive machine for a hospital system to have. And so not every neurosurgeon does focus ultrasound. So I think when you talk to somebody who has experience in both, then they are able to really give you their unbiased opinion, which one would be better in your situation, because everybody's situation is slightly different. There are some things that would keep you from having focused ultrasound that don't keep you from having DBS. Like it's not skull thickness really, but it's a ratio of the hard and the soft bone in the skull. If that number is too low, then you're certainly not a candidate for focused ultrasound. But I think that if you're really torn between the two, then really having a conversation with somebody who has done both, has experience in both, is important. If you're not torn between the two and you're like, hey, I really want X, I think it's still, neurosurgeons should be doing these procedures. It's still important to talk to a neurosurgeon who does focus ultrasound and ask them about DBS. It's going to be folks who do DBS who are also doing focus ultrasound. It's a subspecialty. So I think that that's super important, but I think it's a multidisciplinary conversation, right? You are the most important. What you want is the most important, but getting information that is very clear about both options and being able to weigh for you what's best is incredibly important. If you only go to somebody who's DBS, they're going to go like, well, I don't know. I think DBS is the way because this is what I do. If you go to somebody who only does focus ultrasound, well, I don't know anybody who does only focus ultrasound, but then they're going to say, well, this is what I have to offer you. So this is why. But if you speak to somebody who has training in both, who has performed both, then you can get a really clear option. And I think you ask the critical questions. Why for me is what are the disadvantages and advantages in my case, right? Because everybody's different. For instance, one of the downsides of focused ultrasound is it can affect balance. So if you already have a balance problem, I probably would say focused ultrasound's not great. DBS can be a little bit better. So it's very, very, very important to get all your information and to have control of your own health and be your own advocate, because not everybody is going to be advocate for you, even in the healthcare system.
Yeah, and also just to drive home another point you said, you mentioned a lot of different people that you might talk with. So, it's probably a good idea to talk to more than one person to get information more broadly than just one consult. And in fact, you sort of have to, right? I mean, if you're going to think about DBS, you'll talk to a neuropsychologist and et cetera, et cetera. So just making sure you're not taking one piece of information and assuming that's the comprehensive view of the circumstance you're in.
I think I advocate for my patients to get second opinions. I'm never offended or upset if a patient wants a second opinion, because the way somebody else, they may not click with me, they may click with me, but I didn't provide them with information in a way, or somebody else didn't. It's never my problem. I want to treat people who are ready and who are good candidates and whom we can help, but also who feel comfortable doing it. And I want to make sure that they have that. And so when people say to me, "Hey, do you have the name of another person?" I'm totally going to give them somebody else. I have zero ego in this. It is all about what's right for that person. And really, I have to say that that should be the approach across the board. So you should always feel free and empowered to ask for the name of a second opinion. Or if you don't feel comfortable with that, going out and finding folks who have second opinions, and those are pretty easy to find. You just Google DBS, and they have all kinds of connect me to doctors. Same thing for focused ultrasound.
Great. So, well, I think we've covered a lot of ground today, and I really appreciate you taking the time to discuss these topics with me. I wonder if you might have one final word or one final sort of closing thought that you really wish people with Parkinson's just knew about DBS. Is there anything that do you think is the main takeaway you'd hope somebody would come away from this conversation with?
I know I keep harping on it and I've said it before, but you really have that window is so incredibly important. And also the idea that we know, I can just definitively say that it's better than best medical therapy alone for your quality of life. And so deep brain stimulation is a way to live better. Our whole thing at Davis Phinney Foundation is how do you live well today? And DBS has overwhelming data that it can help you live well with your Parkinson's today and in the future.
Well, Dr. Beasley, thanks so much for taking some time to talk with me. It's always great to connect with you, and we appreciate all of your time and sharing your expertise. And I'll look forward to talking again with you in the future.
My pleasure.